I'm going to talk a little bit about work that we did a couple of years ago as part of the Better Start Mental Science Challenge, which I was involved with, working with the Ministry of Pacific Peoples to do a project on mental health of Pacific peoples. My background was actually, before I started analysing whole population data, I was a mental health researcher. I worked on longitudinal studies mainly, looking at mental health and family influences on mental health. So hadn't looked at mental health in Pacific peoples specifically so much, but Jesse Kakaua at the University of Otago, and Troy Rohi for that matter, the University of Otago, had done, Jesse for a long time. We approached the Ministry of Pacific Peoples about their interest in this research. We had some resource available essentially to do research in the Pacific space. So we approached the Ministry of Pacific Peoples and say, hey, what would you like to do? And they said, we'd like to look at mental health. And so that's how it sort of came about. That's the team. That was a gorgeous day down in Dunedin when we visited Jesse. So myself, Anita Atta Forrest, that's Rose Richards, who was there on the day, who I've known for a long time, and works in sort of Pacific health space as well. Jesse, and then Troy Hill, I think he might have been in Cook Islands at the time. That's him there as well. So I've talked about this a little bit already, but it's a partnership between, or was a partnership between the Ministry of Pacific Peoples and the Better Start Big Data team. So that was the team that I led. Steph was involved in that team as well. Jesse was involved in that team. So the Better Start National Science Challenge finished middle of about a year ago. And our role was to kind of support the other themes by analysing big data that help them. And I'll get onto this, I think, probably the next slide, but maybe I'll say it now anyway. The other themes were focusing on healthy weight, resiliency, so mental health, so this is what this sort of falls under, and successful learning, education. And one of the reasons the Ministry of Pacific Peoples wanted to do this, one, it was part of their Langimalie goals, which I used to have a slide on the Langimalie goals, but I've taken it out partly because I don't think that's the framework they're working with at the moment. There's been a bit of a change in Ministry of Pacific Peoples. But it's the first time since Te Rao Henengaro, which was a mental health survey, I think 2003, again, I've got it on the latest slide, that looked in depth into mental health population level for the Pacific population. And one of the themes of this talking about together is the data isn't as good as it could be for that purpose, but it's the best data available. And so the conclusion is we need better data. But the study focuses on both adults and children. I'm going to talk about the adult results, not the child results, using the New Zealand Health Survey. So the New Zealand Health Survey is kind of runs ongoing, and it captures the health of the population of New Zealand. So you want the prevalence of cardiovascular disease, that's what they go to. You want the prevalence of smoking, that's what they go to. The prevalence of depression, etc., along lots of different dimensions. Also looks at healthcare access and various other bits and pieces. It was put into the integrated data infrastructure, which you've heard about a bit, I know 3 or 4 years ago. And so we thought, well, we could utilize that within the integrated data infrastructure to identify Pacific populations at the, not just at the UR Pacific level, but Tongan, Samoan, and Māori level as well, using data that's in the integrated data infrastructure, as well as other data that's in the integrated infrastructure to understand Pacific people's mental health, essentially. And that's the disclaimer, which you would have seen from Natalia before. Okay, so this is the bit I've already said where there's those themes. There's also a Vision Mataranga theme, who we all met together, but we didn't do any big data work with them. We did big data work with the 3 themes above: healthy weight, resilience, and successful learning. And we, as I mentioned, wanted to answer questions relative to Pacific peoples, and they wanted, this was them saying to us what they wanted to look at mental health, why this came about. Okay, so a little bit, again, I'm not an expert on Pacific people, more experts. We're in the Langimalie Research Centre, that's where the expertise is. But there's a little bit of background. I'm showing you the 2018 data because it was the data that was available at the time when we did this. There's subsequently the 2013 data, and I think the population's grown by 60,000, it's now 440,000 Pacific people in New Zealand at 2023, would have grown since. And I was mentioned earlier, why not Samoan? And you're right, like 48% of the Pacific population is Samoan. And that's going kind of decreasing populations, Tongan, Kakawa, Māori, Niuean, Fijian, Itian, Kokolauan, Tuvaluan, Kiribati, Tahitian, etc., etc., etc. So diverse population from, Pacific Islands, the biggest ocean in the world, and covering a lot of that ocean. At the time, 380,000, multi-ethnic population, that is not just people may be more than one Pacific ethnicity, they may also be Pacific ethnicity and Māori, or Pacific ethnicity and European, and you see that a lot. A very young median age, the youngest of the major ethnic groups population in New Zealand. I've become really interested in demography just by doing the research that I do, and New Zealand's fascinating in that the sort of four big ethnic groups, New Zealand, European, or European, Māori, Pacific, Asian, have four quite different age pyramids. I mean, Pacific and Māori are relatively similar to each other, but a Pacific young shifted. Third of the Pacific population under the age of 15, 2/3 living here in Auckland, 2/3 now born in New Zealand. And what you see there is that there's a real age gradient there. The younger ones are more likely to be born in New Zealand, and the older population less likely to be born in New Zealand. And lots of research on the high unmet health need in that population. In terms of what's already known, there's been kind of sporadic stuff through time, but not much recently. So there was lots, and these are really interesting. Troy Ruhi did the review of this for the report. Studies in the early 1990s focusing on particular migrant communities more than anything else, indicating high levels of psychological distress, struggling a little bit or a lot. And they tied this a little bit to immigration experiences, kind of living situations when they get to New Zealand, discrimination when they get to New Zealand, adaptation to a new society, contributing to the mental and physical distress. Diagnosis was lower, so lots of distress being reported, but when you look at those who've actually been diagnosed, this is a theme of this morning, those who've been diagnosed with in this case, mental health condition, half the rates of non-Pacific. The Te Rao Hinengaro in 2003-4 probed this in more depth and did something that I wish they'd carry on with the New Zealand Health Survey, which was really good, which they oversampled Pacific. I mean, Pacific are 8% of the New Zealand population, something like that. And so 8% of 13,000 doesn't get you very many people, it's about 1,000 people. They doubled that, which means you can drill into in more detail what's going on with the Pacific population. And what they found is higher psychological distress following on from what was known in the 1990s, higher alcohol and drug use, but lower service use. And the reasons they put the lower service use down to was unfair treatment experienced in healthcare settings, just access barriers, not knowing what services were available or not being able to get to the services. And also they highlight, there may be some, in this area, particularly mental health, there may be some stigma in accessing services or preference just for not accessing those services. And this is something, again, just a foreshadow that you'll see with the results of the inquiry, that while there's lower service use, there's actually amongst specific peoples compared to non-Pacific peoples, there's higher rates of distress. Different point. Higher rates of distress diagnosis amongst New Zealand-born versus Pacific-born. And part of that might be an access barrier issue where some of those access barriers are removed after time. Okay, so what we wanted to look at is, do Pacific people with mental health conditions differ from the overall Pacific population in their age, ethnicity, gender? What factors kind of are associated with having a mental health condition? Do Pacific people who deal with issues related to mental health differ in their educational status, their financial situation, their income, labor force status, housing tenure, their housing situation, and their neighbourhood deprivation from the overall Pacific population? What's the trends looking like? What's happening with mental health in the Pacific populations over the years we're able to look at, which were 2011 to 2021? And because we've got that, we can look at, well, is there evidence for an impact of COVID on mental health in Pacific populations? Because we had 2 years of surveys pre-COVID and 2 years of surveys post-COVID that enable us to look at that question. In terms of the methodology we use the Divide Research Framework. Divide, you may know, quilt, Cook Islands quilt, and the methodology translates the steps in putting together the quilt into research steps. It was developed by Te Moana Maua Hodges. That's her second from the left there, with Anita and Ata, and I think that's Maureen Beetham. Anyway, it was developed by Te Moana Maua Hodges for education research, and that had 5 steps that matched the steps of making a Divide. It was modified by Jesse and others for use with the integrated data infrastructure, and that had 6 steps. And then I wasn't part of this discussion, but Ata and Anita and Jesse met with Te Moana a couple of years ago now, 2.5 years ago now, December 2022, to decide the particular steps that we should have for this project, and we came up with 8 steps, which are those. Te Aroma, that's so having a vision for the Divide and translating to research, planning, shaping, and forming the project and team. I've talked about that already, about the steps that we've taken for that. What I want to talk about for the rest of the talk is how we went through the other 7 steps. Akaruru, the design and methodology. So that's the design, consider the design of the Divide, including the colour, material patterns. And we're considering the selection of appropriate frameworks, the IDI datasets, the tools, etc. Toki, cutting the pattern and patches for the Divide. So we want to select the indicators that we want to look at, the variable construction. Te Mumu, making sure the pattern patches are what you want it to look like. That's translated to the analysis, to review the analysis. A Tui, sewing the pattern together. That's interpreting what's going on with the data. Akamania, tidying up the Divide, beautifying it. So it's verifying and summarizing the findings, articulating, concluding the recommendations. Ariki Anga, making the final touches. It's validating the findings and getting the peer review done. And finally, order, revealing what has been done. So that's the sharing of the findings. So we went through all of those 8 steps, talked about the first one. I'm going to talk a little bit about the final 7. Now, so source of data. You've heard about, and Natalie showed pretty much that image on the right-hand side there. That's the integrated data infrastructure. And as I mentioned, the health survey has been in there for a few years now. Only 2011 to 2019. There's more health survey data outside of the IDIs I'll get on to shortly, but actually mentioned there. The New Zealand through the Data Explorer, so you can go online to that link there and see, and actually look at specific results for that matter on other health survey indicators by going to that link. For the adult population, we looked at, and this again picks up on some of the discussions we were having this morning, doctor-diagnosed depression, anxiety. The survey question is, when New Zealand Health Survey goes to people's households, sits down with one adult from the household and asks them a series of questions. The question they ask in this regard is, has a doctor ever told you that you have depression? And has a doctor ever told you that you have anxiety? So it's self-report about a medical encounter. Primary care medical encounter, probably. And then self-reported psychological distress, that's a validated scale called the Kessler 10, which asks 10 items about how you've been feeling in the past 4 weeks. For children, I won't touch on the children's results in the interest of time, but we looked at the Strengths and Difficulties Questionnaire scales, which is a scale asked of parents and also early childcare teachers where available. And that was just for a selection of years. Okay. So that's the number of people who are in the New Zealand Health Survey, which is around 13,000, which is the same as Te Ngaro. But you can see the number of Pacific adults in there, whereas they had 2,300 something Pacific adults in the Mental Health Survey. There's less than 1,000 in each year. You can also see what happened kind of during the COVID times, where maybe you can see the numbers really dropped away there. Difficult to get people's elements. Number of children there as well. And the way it worked, getting the New Zealand Health Survey into the IDI is because you're doing a survey and the people had to consent to the survey, they also asked consent if their data could be linked to health data and wider data, in this case, the IDI. So not everyone who did the survey agreed to have their data linked. So when we go to the administrative data, we have a small number still. Got a bit better over time, but you're still down the sort of 600, 700, 820 number rather than the 830 to 900 number. We use both these data sources, the data sources from outside the IDI, which goes to 21, 22, and the data sources within the IDI, which stop at 2019, prior to COVID. I've gone through the indicators that we honed in on. These are the three that were available for adults: the diagnosed depression, anxiety, and the psychological distress scale. And those were the 5 strengths and difficulties questionnaire scales we looked at for children, which I won't touch on, but they're listed there. And then the other indicators that we get from other data in the IDI, so these weren't necessarily part of the survey, but were available in the IDI. We can look at age, we can look at ethnicities, and we looked at the 4 largest Pacific ethnicities, as well as people who said they were European, as well as people who said they were Māori. Gender, where they were born, and geographical location, sort of broken up by groupings of DHBs, with 3 Auckland DHBs, and then 2 other areas actually. Level of education, income, their employment status, whether they owned or rented, their crowding situation, and the deprivation of their neighbourhood. Some watch Natalia, because they really have deprivation stuff, certainly. Okay, on to the results. Demographic correlates. And each of these panels will show a different outcome. So for doctor-diagnosed depression, estimated to affect around 24,000 Pacific peoples in 2021, 2022. That's 1 in 12 Pacific people. Overall lower prevalence than non-Pacific, increasing slightly over time. Far more common in women than men, which is common of depression generally. That's not specifically a Pacific thing. Twice as common as New Zealand born than overseas born, and highest in mid-adulthood, 25 to 54. Anxiety was similar, 25,000 Pacific people estimated, lower prevalence in non-Pacific. It's increasing at a greater rate over time, about 0.7 percentage points per year. Also more common in women than men, which again is something true of the general population. Also twice as common in New Zealand born than overseas born, and highest in the slightly older ages, 45 to 54. I should say at this point, depression and anxiety overlap really, really strongly. Being depressed is anxiety reducing, and being anxious causes depression. Psychological distress shows something different. Affects far more people. This is those who have high psychological distress, and there's, you can argue about where the cutoff should be. There is a cutoff they give. We use that one. That has higher prevalence in non-Pacific. So let's pause here. So when people ask, did a doctor tell you of depression, or did a doctor tell you of anxiety, they give a relatively low number. But when you ask them questions about how they're feeling, a greater number of Pacific say they're feeling in not such a good way than non-Pacific. It's also increasing over time. Also more common in women than men. Again, that's true of non-Pacific as well. No difference between New Zealand born and overseas born. Pausing here for a second. Is it because New Zealand born are more seeing a doctor for their condition and saying, hey, I'm not feeling so great, than people are not born overseas? Because you see no difference when you ask them about their symptoms. And also no difference across age. In terms of socioeconomic correlates, depression tend to be associated with people who are in lower income, more likely to be unemployed. It's actually lowest among those who live in overcrowded houses, and no deprivation grading whatsoever. There's mixed evidence, I think, internationally and in New Zealand about the impact of socioeconomic status on depression and anxiety. Some find it, some don't. Anxiety is similar, again, noting that they're very similar conditions. Associated with lower income, also lowest amongst overcrowded houses, and highest of those amongst those living in the least deprived areas. That's kind of almost has a double negative. So if you're living in affluent areas, that's when you're more likely to have a doctor diagnose you with anxiety. Psychological distress, on the other hand, decreases with increasing education. So if you have those who have lower education levels can have the higher psychological distress. If you're in lower income, higher psychological distress. If you're unemployed, higher psychological distress. If you live in a rented home rather than owned home, higher psychological distress, but no deprivation gradient. Noting also, the one thing I didn't note before, and maybe you're aware, but roughly just under 50% of the Pacific population in New Zealand live in the highest deprived quintiles of neighbourhood deprivation. So it's a very skewed distribution population, so high levels of neighbourhood poverty. Okay, COVID. Looking at the 2 years prior to COVID and the 2 years after COVID hit, and looking at rates of depression, anxiety, and psychological distress in Pacific mental health, what do you think? Do you think there's any evidence there that COVID had an impact? For me, I might say, well, it looks just to be going up over time anyway. I mean, COVID didn't really bend the curve. And moreover, that's the end of the point I agree with me. Those are the error estimates around those numbers. So with the numbers of people we have in the New Zealand Health Survey, with relatively low prevalence conditions, you don't have very, very accurate estimates of the prevalence. And so you can't really tell a good story about whether something has changed over time. Because that 8.6 in 2020 anxiety could be anywhere between 4.5 and 12.5. So we're underpowered. Okay, Tui, summary of key findings. Lower prevalence of doctor-diagnosed depression and anxiety, but higher prevalence of self-rated psychological stress. They're kind of measuring similar things, but they're telling different stories. Yep. I put this down to access barriers a little bit, and it's been a consistent, but there might be other interpretations. So you're getting my interpretation here, there may be others. I think it's possibly an access barrier, and it's been a consistent finding over the last 30 years. The previous studies that I mentioned show the same thing. Social currents largely expected, though affluence sometimes associated with higher rates of doctor-diagnosed, especially anxiety. So that's where, again, this fits with an access interpretation where those who live in more affluent neighbourhoods don't have those access issues. New Zealand born also report more doctor-diagnosed depression and anxiety, but not more psychological distress. No evidence of COVID impact, but we're very poorly powered to detect going on. More generally, though, and I have slight arguments with people about that, I don't see good evidence in New Zealand that COVID had an impact on mental health. Mental health in New Zealand, problems in New Zealand have been going up generally. I don't think COVID actually changed that. And actually, anything psilocybin stuff down. Okay, conclusions and recommendations. Pacific people's struggles with mental health are often hidden. You find out more about it by asking questions about how they're feeling than seeing if they've seen services for things. Because services are not always accessed. And also, the New Zealand Health Survey is not well placed to investigate correlates or trends of low prevalence outcomes broadly, and mental health specifically, because it is a low prevalence outcomes amongst minority population groups, because they make no effort to oversample smaller subgroups of the population, which they could do this. It costs a bit more money, but I think it adds greater value to the survey. And when I've talked to people about this, it really has come down to, well, no, costing. But it's a heck of a lot cheaper than running another one of those big surveys. And survey is needed because the services are not always accessed. You can't just rely on IDI type stuff, which gets you service access. You need survey information. Okay, so we have 3 independent reviewers of the report. two from the Ministry, two from the Ministry, one from outside. It's published there, it's published on our website. It's a slightly awkward URL there, you can get to it there. Also, there's a couple of copies over there. I brought more along, but I see some of them have gone already. So this is the order. We're presenting it to you, sharing the findings with you. So, my Martha, thank you very much.
Yes, just regards to the results regarding the overcrowding, it looked like there was a particular factor growing.
It did, yeah.
I think it's sort of culture,
yes,
collective nature of our business. Why we stick together and support.
That's an interesting thing. So this is where there was. I'm coming from a not as a cultural point of view. It's probably an access thing, and but when I talk to Ata particularly. And Jesse, to some extent, they're saying that there's a support of they may be overcrowded houses, but there's lots of family around you in those houses. And so that you're right, they may be a protected thing. Sorry, you're going to.
I was just going to say, was that for the psychological distress measure, or just for the doctor diagnosed?
It was for the. I think it was for the doctor diagnosed one. But I accept that that's a reasonable interpretation.
Mm.
Highest rate, as you would know, of multi-generational households in New Zealand.
Do you think Pacific being able to articulate what they're going through also impacted some of your results? There was some that there was low access, and it's because people can't articulate, what they have, or they can't explain what they have. But you said when they ask how they're feeling, they're saying they're not feeling that great.
I mean, possibly. I mean, there's the question is, has a doctor told you you've had depression? And I don't work in primary care setting, but there may be difficulties in articulating that to a professional in a healthcare setting. I think the survey questions. I don't think there's an issue with that particular survey question, but there may be. Just articulating how you're feeling in the healthcare settings issue.
I think it's because it's not about, it's about who's being asked about their mental health. So if you go to a doctor and you're feeling you've got abdominal pains, are they asking how's your mental health? Because if you ask someone about their mental health, they'll start telling you about it. But if you don't ask them, they're not going to come to you and say, I've got depression. Doesn't happen. So it's about, I would love to see a question where it is, has the doctor asked you about your mental, like I was saying with the neurological conditions, people aren't asked. And often the focus is on, are you smoking? Are you eating healthily? It's not on asking people about their mental health and whether they're okay. That's what needs to change.
I wonder if there's two other things in addition. One being the stigma of mental health. I've recently done a project around gout, and it's got stigma and things not to talk about. And the second one, maybe they don't see the doctor being do anything about their mood anyway, which is not completely unreasonable.
That's a really good point.
Yeah, I think so too.
Then before it needs to be.
Yeah. Oh, sorry, that's mine. That was.
So I'll make a comment as a GP in clinic, worrying about 15, you're not saying if someone comes with
Yeah,
problem,
of course.
that's off focus.
I know, right?
It's
Yeah,
very hard
of
to
course.
start exploring other
Yeah.
things, especially with our Pacific patients. Some, when it comes to age groups, youth will come in and say, I'm here for a check. But we interpret that there's something else going on. With our Pacific, we have to look into the things they have to say as well. So, yeah, it depends on
So just because I forgot your second point, which is really what one.
Maybe the doctor can help.
Right, thank you. Yes. Yeah.
I guess linked to that, my understanding of seeking help rates is quite low from healthcare Māori therapists.
Yep.
So is there any data around that if you're seeking help and to mention that?
I mean, the New Zealand survey asks about if you've ever wanted to see a doctor but couldn't. So it's really about the access issue. Not specifically that. Well, I don't know at least about data that's looked at that. Others might.
The prevalence versus the intervention, right?
Mary, I'm just thinking you're relying on an individual to see a care professional and tell you about this situation.
Well, the survey is.
The survey,
yeah.
is it possible, does the survey pick up that maybe someone else that is referring to the healthcare professional that they think this person needs help?
The survey doesn't. The survey is a individual interview, so it asks about them and their situation, and sometimes about their children. But yeah, I mean, yeah, it's clear that this isn't picking up all the depression and all the anxiety that people, let alone specific people, have. I think, and that's why I do like the psychological distress, which I don't think it's been validated for specific people as far as I'm aware. But asked about have you been feeling low and down in the last 4 weeks, and various questions like that. So face validity at least. So I coming from that background as well, I like scales measuring mental health rather than just has the doctor told you that. Because people, I'm not sure people are always cognizant that they themselves have depression or anxiety either. Picking on those two. Yeah.
So where to from here?
I mean, I'd like to, I have in a very minor way, but not with any great force, I'd like to advocate for an expanded New Zealand health survey. I just think it's a cheaper way to do things than running a big specific mental health survey again. The advantage of a big specific mental health survey again is you get more than anxiety and depression and alcohol and drug, which is the other things I asked about. You'll get the psychosis, you'll get the eating disorders. There's bipolar, I think, in the New Zealand health survey. But in terms of serving smaller communities, such as the Pacific community, I think running the same survey, but running it with a different sampling methodology would be the way to go. Because you're not harming the bigger groups doing that. You're just helping the smaller groups. So, for me, it seems like a fairly straightforward solution. Well, it will cost more money, but it will cost less than having all this problem out there that is just not aware of. I don't know. I mean, they managed to get 900. If they try twice as hard, they'll get 80, kind of thing. So,
Is there any utility of the Dunedin cohort study? Does any of your work at Plunket sort of do that?
We have. I mean, my background is working with the meta study, I should point out. We have used it on a few things. We have written papers where we've looked at a particular issue in the whole population and then gone into greater depth in the meta study. It's great for looking at lots of mental health conditions, as is the corrosive study and the growing up study, and the Pacific Island family studies actually as well.
Yes.
But yeah, I've got affiliations with them and do a little bit of work with them, but it hasn't been a big part of our work. So I think that's been fair to say. If you look at our publications, there's a few that I'm involved with that are publications for the Dunedin study, but probably more actually with growing up with Steph and Lisa actually.
Yeah, but given the age of the Dunedin study participants who are now
52.
Yeah, there's probably the importance of that study for older people is because they have so much data going back in time.
I mean, it's a study of aging now. They're known that for 15 years.
Of course. But it's not very good for data on.
It's not very good for data.
People.
It's, there's moves to join the Christchurch and Dunedin study together for the purposes of looking at Māori, but that's still much more Pacific. Again, one of the values of the growing up in New Zealand studies, based in Auckland and Waikato, it's got pretty chunky numbers of European, Māori, Pacific Asian. With the decision to not keep them all going forward. But, it started off with 6,800, was it? And there were over 1,000 of each of those four groups, I thought.
Something like that.
Yeah.
I should know.
Around 1,000.
Yeah, I think maybe I think about 800 mums were Pacific because we did the because we found exactly the same when we looked at maternal perinatal depression.
Yeah.
Really high rates among Pacific women of I think it was antenatal and postnatal. But they, when you looked at the number of those women who had been diagnosed with depression.
Yeah, you see a completely different trend.